Guide to the graphic. Here we have depicted the conduction system of the heart. Here we have the sinoatrial node, or the SA node, the pacemaker of the heart. Then the signal from here is conducted in a wave-like fashion down through the atria to the atrioventricular node, the AV node, then onward into the ventricles, to the bundle of His, and then down along the left bundle and the right bundle branches to the Purkinje fibers. Specific bradyarrhythmias. Specific bradyarrhythmias include sinus bradycardia, sinoatrial block, atrioventricular block, sixth sinus syndrome, and left and right bundle branch block. Sinus bradycardia, a sinus rate of less than 60 beats per minute, may indicate excellent physical conditioning. However, in the elderly, it often indicates intrinsic sinus node disease. Inferior myocardial infarction, hypothermia, myxedema, or increased intracranial pressure may cause this arrhythmia. A longitudinal study of apparently healthy persons between 40 and 80 years of age with sinus rates of less than 50 beats per minute found no increases in cardiovascular morbidity or mortality over a 5-year mean follow-up period. Sinoatrial block occurs when sinus node impulses fail to depolarize the atria. Such block is often 2-to-1, resulting in a ventricular rate that is exactly 1/2 the sinus rate. Common causes in the elderly are intrinsic conduction system disease, ischemia, and digitalis toxicity. First degree atrioventricular block. Prolongation of the PR interval of greater than or equal to 0.22 seconds may be seen in healthy persons with high vagal tone. It also may be caused by intrinsic conduction system disease or by various medications. For example, digoxin, beta blockers, calcium antagonists, and class 1A antiarrhythmic drugs. No therapy is required. Second degree atrioventricular block has 3 different patterns. Mobitz type 1 or Wenckebach block is recognized by prolongation of the PR interval that progresses until a ventricular complex is dropped. Because this type of block is usually proximal to the His-Purkinje system, the QRS complex typically appears normal. Digitalis toxicity and acute inferior myocardial infarction are common precipitating factors. This conduction disturbance is usually transient and rarely requires specific therapy. In Mobitz type 2 block, the PR interval is fixed, but QRS complexes are dropped. Because the site of block is at or below the His bundle, the QRS complex is often wide. Mobitz type 2 block is most often associated with acute anterior myocardial infarction, myocarditis, or advanced sclerodegenerative conduction system disease. Patients with this arrhythmia are usually symptomatic and often present with syncope due to inadequate cerebral perfusion, Stokes-Adams attack. Because of this symptomatic presentation and frequent progression to complete heart block, Mobitz type 2 block is usually treated with a permanent pacemaker. Similarly, high-grade block is often symptomatic, may progress to complete heart block, and is usually treated with permanent pacing. Third degree complete atrioventricular block is characterized by the inability of any atrial depolarizations to activate the ventricle. Block within the atrioventricular node is usually associated with normal QRS complexes and an escape rate close to 60 beats per minute. Common causes are acute inferior myocardial infarction and digitalis toxicity. In most instances, block within the atrioventricular node is transient. However, block within the ventricles is accompanied by wide QRS complexes and a slow escape rate, often less than 40 beats per minute. Such block may occur in patients with severe sclerodegenerative conduction system disease or extensive acute anterior myocardial infarction. Because these patients usually respond poorly to atropine and isoproterenol, pacemaker insertion is necessary. 6 sinus syndrome encompasses a variety of rhythm disturbances that reflect sinoatrial node dysfunction and are often associated with dysfunction elsewhere in the conduction system. Although 6 sinus syndrome is associated with many different cardiac diseases, coronary artery disease or a primary sclerodegenerative process is most often responsible. Patients may present with bradyarrhythmias, sinus bradycardia, sinus pauses or arrests, sinoatrial exit block, or atrial fibrillation with a slow ventricular response, or with the so-called bradycardia tachycardia syndrome, in which a supraventricular tachycardia terminates in a long period of asystole. Therefore, symptoms may consist of palpitations or chest pain during tachycardia and dizziness or syncope during bradycardia. The tachycardia, paroxysmal supraventricular tachycardia, atrial flutter, or atrial fibrillation is treated with digoxin or other antiarrhythmic agents or cardioversion. Bradycardia associated with syncope should be treated by permanent pacing. And that is specific bradyarrhythmias. Have a great day.